Hello everyone, John Strzelecki here. It's a pleasure to present a short overview of the technique that Dr. B.J. Palmer used as he developed the gift of chiropractic that he inherited from his father, D.D. Palmer. Before we do that, however, a little bit about myself. I'm a 1974 graduate of Truman University in Kirksville, Missouri, where I received a Bachelor of Science degree in biology. At the same time, I received my U.S. Army Reserve Commission in Field Artillery. In 1979, I received my Doctor of Chiropractic degree from Palmer College of Chiropractic in Davenport, Iowa. In 2009, I received a Master of Science degree in Education from Western Illinois University. Following graduation from Palmer, I spent 2 years in associate practice before returning to the Quad Cities. On my return, I joined the faculty at Palmer, where I educated students for 30-plus years. And I also have been teaching at Logan as an adjunct faculty for 20-plus years, of which I continue to do today. Upper cervical toggle. Well, what is upper cervical toggle? Well, the foundation for this technique will be explored in future slides, so hold on. Required text. The required text for the class is the Essential Toggle Recoil. The book also comes with a flash drive. Within the book and the flash drives is all the information you're going to need to navigate through the 3 weekends that we're together. In the flash drive, there's a number of folders. One folder is a flowchart folder, a handout folder, a PowerPoint folder. The PowerPoint folder will contain all the presentations that we'll do in the 3 weekends that we're together. We have a Titron folder, which is going to be information about instrumentation. Instrumentation is going to be the major determining factor whether we're going to adjust or not going to adjust. B.J. Palmer said it's just as important to know when to adjust as it is to know when not to adjust. And then we have a video folder which contains 3 videos. One is the CET video. CET stands for Case, Evaluation, and Thrust. That will be your final setup practical, which we'll see if you can pull everything together, the x-ray, the setups, and actually make an adjustment on Charlie, the mannequin. Speaking of Charlie, we have a setup folder, which we'll all be doing all the setups of the atlas and the axis on Charlie, showing the proper protocol, the proper setups, the practical line of drive, and kind of add a thrust to make the adjustment of an atlas and an axis. And then we have a vintage video, which shows Dr. B.J. Palmer making some adjustments in cervicals, some thoracic adjustments, some lumbar adjustments. There's a video of the Palmer Research Clinic. Some of it's narrated by Dr. Clay Thompson. You'll see Dr. B.J. Palmer making a side posture adjustment on a Thompson table. Just an enjoyable video, which I think everyone will enjoy. The class is broken down into basically 8 sections. One's philosophy. We'll talk about some B.J. Palmer philosophy, some methods of adjustments, the rationale for the upper cervical adjustment. We'll define the technique. What do we mean by toggle and recoil? And we'll spend some time with x-ray. Everyone will have an opportunity to draw some lines on x-ray in the view box room to determine an atlas and axis listing. We'll spend time in instrumentation. Again, instrumentation is a major criteria for when we determine whether to adjust or not to adjust. So we'll spend some time running scans on your partner and maybe perhaps make an adjustment at the end of the 3 weekends together. And we'll spend some time on leg checks. We'll do supine leg checks on the toggle table, supine leg checks on the Thompson table, and prone leg checks on the Thompson table. And then we'll do some setups. We'll do all the atlas setups, all the axis setups. We'll do all the setups on the toggle table. And we'll also go to the Thompson room and do the same setups on the Thompson table. Evaluation procedures, about half and half. About 50% of the testing is going to be written and about 50% is going to be practical. So it's a good combination of both. Philosophy. We're going to spend some time talking about philosophy, but it's going to be B.J. Palmer philosophy. Most of the information is going to be gathered are from the green books that B.J. Palmer authored. B.J. said for true subluxation to exist, there need to be 4 factors: an occlusion of an opening, vertebrae alignment, pressure on nerve tissue, and interference with flow of mental impulse. The most important being that the interference with the flow of mental impulse. That's why Dr. Palmer used instrumentation as that guideline for determining whether there was a subluxation or not. B.J. Palmer also differentiated between a misalignment and a subluxation. A misalignment, while important, does not need to be adjusted. A subluxation, on the other hand, does need to be adjusted. There'll be a lot of times you'll have a misalignment, which will be a compensation for a subluxation, and again, does not need to be adjusted. We'll discuss the details. BJ said if chiropractic works, it should work 100% of the time. He said if it's a chiropractic-based problem. And he says it does if you get the right adjustment, the right place, the right time, and in the right manner. And we'll discuss all those items as we go through the class. Of course, the right adjustment is a toggle recoil adjustment, the adjustment that we're going to be going over in the next 3 weekends. B.J. Palmer talked about 3 divisions of intelligence. He talked about universal intelligence, he called the source, innate intelligence, he called the semi-source, and educated intelligence, which he called the non-source. We'll discuss and differentiate the difference between the 3 and why they are important. Why upper cervical? Well, when they asked Willie Sutton, why do you rob banks? He says, well, that's where the money is. Well, when they asked B.J. Palmer where the subluxation is, B.J. Palmer thought the most important subluxation was at the upper cervical area, which is the reason we'll discuss as we proceed. You know, the upper cervical area from your anatomy is very important. The upper cervical area, the atlas itself, has got a lot of range of motion. It can either rotate, go up superior this way, the anterior tubercle drop inferior. It can rotate to the posterior, it can rotate to the anterior, and it can go laterally. So a lot of range of motion with the atlas. On the other hand, segments below the C2 and below can only go so far posterior, only so far anterior, where it meets its articular facet. It only can drop posterior and inferior. As it does, as with the other areas of the spine, you're going to have some spinal nerve root encroachment. Okay, so if it rotates posterior, rotates anterior, you're going to irritate the spinal nerves. Not saying spinal nerve root irritation is not important, but again, B.J. Palmer thought the most important area was the upper cervical area. Well, why is that? Well, at the upper cervical area, the atlas specifically, that's where you got the medulla oblongata. You know the medulla oblongata is important. If you look at this image from the Massachusetts General Hospital, you notice that here is the anterior tubercle of the atlas, and the medulla oblongata extends just around down to that level. Depending on the anatomy, depending on the individual, it can either go further down or maybe further up. Why is medulla oblongata important? Well, that's where the reticular formation is. According to the Encyclopedia of Neuroscience, the reticular formation of the brainstem is the most ancient part of the brain and one part that is absolutely necessary to the life of the organism. That's where you have the ascending and descending fibers. So you can see if you subluxate that area, you have all kinds of issues throughout the entire body, just not at a local low back or stiff neck or whatever, it's the entire body. And that's why B.J. Palmer thought the upper cervical subluxation was indeed the most critical. Here you can see that the dentate ligament is one of the theories we're going to be discussing. You can see that the dura mater here in red is actually encroaches upon the bone. The dura mater is attached to the pia mater via the dentate ligament. So you can see if you move the bone, which moves the dura mater, which contracts the dentate ligament, you can see you can irritate the cord at the pia mater. So again, another area for why the subluxation upper cervical area is indeed most important and most critical. We're also going to be talking about the axis subluxation. Okay, this is a crude example, but you can see the axis is dropped posterior and inferior. Maybe not irritating the cord as much, but again, an area that B.J. Palmer thought was critical. Here's a couple images of full spine. Okay, B.J. Palmer thought if you took care of the upper cervical subluxation, the rest of the spine would clear out. You can see the pre on the left, some scoliosis there, maybe not so much, and in the post, this is after 6 months of care. On the second image, you can see a lot of curvature of the spine. After just adjusting the guy's atlas, the spine returns as normal. Okay, B.J. Palmer would contend that the innate intelligence of the body would either contract, relax muscles, ligaments on one side or the other, and get the body to where it needs to be. B.J. Palmer was not concerned with straightening the spine out. He was concerned with adjusting the subluxations. Toggle recoil. Well, why toggle recoil? What's the rationale behind it? Well, let's break it down. Toggle is a knee-leg joint that transmits pressures at right angles. It has two arms that are hinged together at an angle. A force applied at the hinge causing the angle to straighten produces a much greater force at the end of the arms. So it's really the mechanical advantage that we're going to be getting by doing the toggle mechanism. You can see as we make the adjustment, we're going to be contracting the triceps, and we contract the triceps to make the arms go straight, and then we're going to rebound them back. So that's the mechanical advantage you're going to get when you do a toggle adjustment. Recoil. The recoil is the vibratory or oscillatory motion due to innate elasticity of the system in response to the application of a force until a new equilibrium is realized. Well, what does that mean? Well, what we're going to do, we're going to set the segment in motion in the proper line of correction, and it's going to oscillate till it finds its normal position. Here would be an example. Say we have an atlas that misaligns up the articulation, and we're going to apply a force. It's kind of like it's on rubber bands. Think of that analogy. After we set the thing in motion, what it's going to do, it's going to oscillate back and forth along the articulation till it finds its normal position. If you actually misalign the atlas and give a ill-advised thrust and a wrong line of direction, what it's actually going to do, it's going to go ahead and jam the articulation. And that's what we do not want. So we want to make sure we have the proper line of correction, the proper contact when we make the adjustment. B.J. Palmer thought that the thing vibrated and oscillated for anywhere from 2 hours after the adjustment. I'm not sure if it does that much, but after we adjust the patient, we're going to rest them for a minimum of 10 minutes to allow that normal oscillation to find its normal position. Here you can see that an ill-advised thrust would actually jam the articulation, which we do not want. X-ray. We're going to spend the majority of the time the first weekend together talking about X-ray. If you know, X-ray was discovered in 1895, about the same time chiropractic was discovered, and B.J. Palmer started using X-rays about 1910, realizing the importance to be able to see those structures on the film, determine what the misalignment may be and what the potential subluxation is going to be. At Logan here, we're going to analyze the lateral and the ADP open mouth film. Those are the two films that we're going to spend time on and you're going to be tested on in a X-ray exam. Typically, the analysis for the upper cervical work consists of a lateral for the ASAI, which we'll talk about, a Nasium film, which will give you a right or left laterality, a base posterior film, which is going to give you rotation, be it anterior posterior, and the ADP open mouth film, which actually gives you the axis listing. Okay. This will be an example of a lateral film. We'll spend some time going over the lateral film, what the importance of the lateral film is going to be, but essentially it's going to give us either the anterior tubercle going inferior, as displayed here. Anterior tubercle is supposed to be up here somewhere, but it's come down, and it's going to be an AI. If it was way up here, it would be an AS. We're going to correct that element of misalignment by using torque. Then we're also going to talk about the open mouth film. The open mouth film typically would just give you the axis listing, but again, since we don't have the Nasium or the base posterior film, we need to determine both laterality and rotation using the ADP open mouth film. So here's an example of all the lines on the film. You can see we have a right laterality because they got a bigger number on the right, which means that right laterality. You see the spinous process rotated to the left with the body a little bit to the right there, but essentially where it's supposed to be. So our listing would be a spinous left body pivot. And we'd end up at an AIRP and a spinous left body pivot. Then we're going to have to determine what we're going to adjust. Are we going to adjust either atlas or axis? Well, we're going to talk about some constants and variables, a way to determine which of those two segments is applicable for us to adjust. Primarily, you're going to think about adjusting the atlas, but there are occasions where you would adjust the C2. So we're going to talk about constants and variables. If you have a variable, it's the only thing we're going to adjust is the atlas. If you have a constant, you can make a determination. So again, we'll get into it in great detail. Okay, also on the base open mouth film, we're going to talk about looking at shadows to determine some rotation. We'll be looking at the posterior tubercle, the width of the lateral mass, the space between the structures, some transverse foramen, portions of the lateral masses to see if there is rotation. Again, ideally we'd have the base posterior film, but we don't, so we have to use what we come up with. And here's some examples of the different things that we can possibly look for on the ADP open mouth film to give us a possibility for rotation. So we're essentially going to put all the factors together and it's going to come up as a guess. Again, you don't have the base posterior film to actually get a really good handle on the rotation, so we're going to make an educated guess by looking at the films and determine what our listing is going to be. A lot of times we'll just take it as a 3-letter listing because the laterality component of the atlas listing from the open mouth film should be fairly accurate. Instrumentation. Well, why do we spend any time on instrumentation? Well, B.J. Palmer thought it was just as important to know when to adjust as it is to know when not to adjust. Just because somebody maybe has some pain does not necessarily mean they need to be adjusted. If there's neurological interference involved, then they definitely do. Instrumentation is our tool to help us make a determination whether neurological interference actually does indeed exist. It was Hippocrates who observed over 2,400 years ago that body temperature varied when patients were ill. Way back when, if somebody was sick, had a fever, they'd pack them in cold mud, and they noticed that the cold mud would dry at different areas of the body at different rates. So they put 2 and 2 together and says there must be a correlation between illness and body temperature. That's essentially what we're going to be doing, and we're going to be doing it using the Titron 2.0, the Titron 5000 and the 3000, which is a dual probe instrument, which actually picks up infrared. As we run a graph, it's going to have 3 lines on it. The line in the middle is the differential between the right and left barrel. The line on the left is going to be temperature in the left barrel, and the line on the right is going to be the temperature of the right barrel. And we have different graphics that kind of portray the different skin temperature at the different areas. You can see the cervical glide would indicate there's really not a whole lot of variability. In this full spine glide, you can see there's a lot of variability. So we're going to do what we're going to call pattern analysis as we work through it, and we'll discuss later. And also give you a fossa differential. The fossa from right to left should be within 0.5 degrees centigrade. Here you can see this example is 1.39, so the balance is not there, which may be indicative of the patient indeed has a subluxation. We're going to talk about pattern. We're going to define pattern as 3 readings taken within a 24-hour period, all showing a repeatable swing of the graph. A pattern is like a thumbprint for this subluxation. Although thumbprints don't change, subluxations sometimes occasionally do. But for the most part, if the patient has not had any injury, trauma, the pattern is what we're going to be looking for in future visits. So as we do our work, we're going to run a series of graphs, and we're going to determine what we can see what their pattern is. So it may take running 3, 4, 5, maybe 6 graphs. So we want to look at those to find out the one on the day that we be potentially adjusting looks similar to one another. So if we look at these two, this graph, you can see this one, and this one, they show some similarities. So if we overlay all those 3, you can see they're almost mirror images of one another. Not mirror images, they're almost identical to one another, which indicate that is what that patient's subluxation pattern looks like. So every time in the future when they come in and they displaying that thermal reading, that means they need to be adjusted. If they come in and their readings kind of varied from that, that means they do not need to be adjusted because their body's adapting. It's yin and yang, if you would. So we have a pattern, that's the day we're going to adjust. So this would be a day that, say, you will take this reading on the left-hand side, say that's the pattern reading, and the one on the right is today's reading. You can see today's reading looks a lot like the established pattern we may have done maybe a month ago. This patient needs to be adjusted. We have three types of reading. We have a subluxation reading, which means the patient needs to be adjusted, an adaptation reading, which means they do not need to be adjusted, and we have some stress reading, meaning there's something going on which we'll have to kind of investigate. So it's going to spend some time actually establishing the pattern and deciding what we're going to do with it. So we establish the pattern, we'll talk about a typical office procedure. Have the patient come in, acclimate, take some readings, do some case history, do a complete workup, and try to establish those 3 readings within a 24-hour time frame to make the determination whether the patient needs to be adjusted or not. We'll talk about health returns and cycles. You can see this patient got subluxated and they had some downtime, some good time, downtime, but they actually got to the point they actually sought chiropractic care. So when they come in to sought chiropractic care, we determine what their listing is, we determine that they're indeed subluxated, and depending on whether it's an acute case, we may get them back to their normal health line, which is up here in a really quick time, or if it's a chronic condition, it may be a little bit longer. So it's really going to depend on the patient and the chronicity of the subluxation. But instrumentation is by first and foremost the most important factor for us to determine whether they're going to adjust. We also use palpation, we also use leg check, we also use symptomatology, but again, the pattern is going to be the first and foremost, and then we're going to get that by using instrumentation. Leg checks. While B.J. Palmer did not use leg checks in his workup in consideration to adjust or not to adjust, as he did not use motion palpation to make that determination, we actually included it in our workup because what we do, we first and foremost look at instrumentation. If the patient is definitely in pattern, we're definitely going to adjust. If they're definitely in full adaptation, we're definitely not going to adjust. It's when we have those cases where, well, they look like they're kind of in pattern, but maybe not. That's when we use those other criteria. And those other criteria are the fossa check, which is temperature on both sides of the neck, the leg checks, palpation, and symptomatology. And you can see the percentages that we give each of those to make that determination. When we do the leg checks, we can either do them supine, which is face up, or prone, which is face down. And we can use a high-low table or the toggle table. We're going to do both in class. Whatever you do, you want to be consistent. You want to eliminate any possible variability. You want to eliminate variables. So if you do them on the high-low, always do them on the high-low. You do them prone, always do them prone. And then we're going to describe the short leg. It's either going to be a short right, short left, or even. Sometimes we'll talk about the leg checks can also be in a pattern. Again, we're not going to get into now, but we'll discuss that in class. This is just an example of a patient getting a leg check done on a toggle table. And we're going to describe how to set the patient up, what we're looking for, the mechanism, how to set the table up in preparation for the leg check. So we're going to go ahead and do that. Here's a picture of students actually performing leg checks in preparation for student adjusting. In the class, when we get that last weekend together, if we have a good workup, we got instrumentation, we got leg checks, we got some palpatory findings, and there's an indication of a subluxation, the students can indeed adjust one another. They don't have to, but they can if they want to. It's their decision, but leg check is part of the information. We'll also talk about foot flare, okay? Here's an example on the one on the upper left. There'll be no foot flare, which you can say maybe there is some, but we'll just say there's none. Over here, you could say this is a toe out foot flare, which may be indicative of an ilium ilium or maybe not. Or down here, it could be a toe in foot flare, which be indicative of attacks in the ex ilium, or maybe not. We don't care, to be honest with you. We're doing upper cervical. We're just looking for pre's and post. If a patient has a toe out foot flare, you make a toggle adjust with the atlas. We do a post findings and they go even, then that's great. We made some change in the legs. Even though we're not looking for that, we're looking for clear out neurological interference. And we'll actually talk about the proper protocol, proper procedure for actually doing the leg checks, both supine and both prone. Again, since we have no toggle tables in the various Logan clinics, we're going to be doing most of our adjusting and workups on the Thompson table. So hopefully we'll have access to the Thompson room, and we'll go down there and perform leg checks on the Thompson room and get an indication of the leg length, either short right, short left, or perhaps equal. And here's how we do a supine leg check, again noting any foot flare, and again we'll practice this in the room. We'll also talk about a pro leg check. A pro leg check is a kind of a unique leg check, but it helps differentiate between a C1, C2, C3, or C4 involvement. It's just a leg check that gives you additional information on which segment to adjust, be either C1 or C2, because again, that's the ones that we're going to be working with. Setups. To assure proficiency in all adjusting procedures, we will need to practice setups. We will spend time in a PowerPoint presenting the exercises needed to perform all chiropractic adjustments, along with the proper method to obtain the correct contact to assure a corrective toggle recoil adjustment. We'll be doing the setups on 12 atlas listings, 12 alternate atlas listings, 8 axis listings, and also how we do those listings on the pediatric adjusting procedures. We will be practicing our thrust on speeder boards, which everyone should have access to, and also the Charlies. That way, we can actually deliver thrusts assuring the proper line of correction, the depth, and the speed of the adjustment before we actually start doing setups on real patients and partners. We'll demonstrate how to do the Atlas setups on a real patient using the toggle table. This should show an anterior setup. This should show a 3-letter listing. This should show a posterior listing. This will show you the proper patient placement. And then we'll also do the same setups of the Atlas and the Axis on the Thompson table, which we have access to. We always prefer the toggle table. You can see the toggle table is low and allows the doctor to get above the patient to perform the proper adjustments. But since we don't have a toggle table at Logan, we're going to have to do it on the Thompson table, which we will get by. Evaluation procedures. While it will take continued practice and review to become a proficient upper cervical toggle recoil chiropractor, I need to feel comfortable with your progress before I issue you a grade. In order to do that, here are the evaluation procedures that we'll utilize. You'll notice about 50% are written, 50% are practical. The first 4 on the list are to do with the x-ray. The 5% or 5 points is the view box x-ray assignment. That's in time we'll go to the view box room and I'll talk you through the films in order for you to become proficient at actually analyzing film and finding structures. The x-ray exam classroom, that's a closed book exam. You'll be tested on the method of analysis and finding structures, but it's going to be on paper x-rays, so that should not be an issue for you. You'll also be tested on the listing system and some of the other things having to do with x-ray. The next 2, the x-ray take-home assignment and library assignment, those are films, real film that you'll have to analyze on your own, do the best job you can. They're probably not the best films in the world, so I want you to do your best shot of finding structures and analyzing the films. The midterm session exam, that's the big one, 25%, and it's an open book exam. No digital notes, however, only the book. The adjusting simulator, I'll bring a simulator in that will actually monitor the amount of speed and depth you have, the thrust, and that'll be worth 5 points. There's certain criteria you need to meet to get the 5 points. Everyone will do it. Just take practice, practice, practice. The next one is the CT exam, the case evaluation and thrust. That's the one we kind of talked about in the beginning, where you're going to get a case. You're going to have to evaluate the x-rays, evaluate the information on instrumentation readings and leg check readings, and actually deliver a thrust on Charlie. And that's a 20-point exam. The patient workup, everyone will do a workup on a partner, which consists of running scans, running graphs, doing leg checks, doing some palpation procedures, and everyone get to the point that either they decide they want to adjust, if warranted, or they don't need to adjust, but everyone will complete the complete upper cervical toggle recoil workup. And the last one up there, 10%, 10 points, that I want you to read 2 upper cervical articles. Doesn't matter what they're from, where they're from. They could be research articles, just articles out of magazines. As long as they have something to do with upper cervical, that's 10 points. Just get them to me and that'll complete the 100 points. So it's not a large task for you to pass the class, but there are certain criteria that need to be met. If you have any questions about anything, you can contact me at my Logan email address at john.straczewski@logan, or you can go drstraz@gmail. I'll be happy to answer any questions you may have concerning the class. I hope to see you, and good luck in your studies.